You're listening to the Sick and Good podcast. My name is Dustin Messick, RDN. I'm a cancer survivor.
My name is Dr. Colin Goodwin, and I'm a cancer survivor. We're discussing topics related to cancer treatment and recovery while promoting wellness.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment, and before undertaking a new healthcare regimen.
I'm happy to introduce Karla Wilson as our guest for this episode. Karla is a nurse practitioner who has more than 45 years of experience in pediatric oncology. And in the last 15 years has experience working with childhood and adolescent young adult cancer survivorship programs. So welcome, Karla.
Thank you, Colin.
Wanted to have you just tell us about your work and research.
All right, I'm happy to do that. I work at the City of Hope in Duarte, California, and we have a very robust clinical research program where we actually screen childhood, adolescent, and young adult cancer survivors for potential late effects of their cancer treatment. It is a clinical research program, so patients who come to our clinic end up enrolling in this study. We collect data to help us have a better understanding what's happening with cancer survivors, both the good and the bad. We need to have that type of knowledge so that changes can be made to improve quality of life. Because ultimately, when we treat people with cancer, our goal is to give them the least amount of therapy to give the greatest cure rate with the least amount of long-term late effects. Since we've had such an increase in cancer survivorship in both the pediatric and young adult population over the last 40 years, our focus has changed not just from how do we cure people, but how do we cure them well? And so there's been a lot of attention paid to what happens to survivors when they're several years off therapy, when they're 10 years off therapy, 20 years off therapy, 40 years off therapy. So we have a very active component in the Children's Oncology Group, and that is the Long-Term Survivorship, our Late Effects Committee, where lots of professionals, physicians, researchers, psychologists, nurse practitioners, social workers, etc., all work together to look at the literature, to look at the evidence that's published, look at the research that's been published, because sometimes we don't have research. We only have evidence to look at. And so how do we screen people? What are the side effects that we see that people have? And so from that, we have a development of something called the Children's Oncology Group Long-Term Follow-Up Guidelines. That first came out in 2003 as a very kind of, I'll call it a very brief kind of overview and things to look at. And through time, that has become very robust. And I call it our recipe book. It's what we look at to screen patients. So when a patient comes to our survivorship program, and survivorship programs throughout the country do things in similar ways, we give a patient a copy of their treatment summary that is very personalized to them. You were treated for this cancer, you had these, whatever stage, if it's a cancer that's staged, you receive this protocol to treat your cancer, you receive these chemotherapy agents to treat your cancer. We know that this chemotherapy has the potential to cause this problem down the road. We know that this chemotherapy, that we don't have any evidence that there are any long-term side effects from that chemotherapy. So then based on the patient's individual treatment, we actually call it treatment exposures, we then say, you had this with our current knowledge level, we need to do this. So for an example would be, you had chemotherapy that included a chemotherapy agent called doxorubicin. That's in a category of chemotherapy agents referred to as anthracyclines. We know that anthracyclines can impact your heart function. We also know that the risk of it impacting your heart function is based on the dose. So if you had very low dose, you don't need very frequent screening. If you had high dose, you need to be screened every 2 years. And the reason for that screening is if you're starting to develop a problem, we want to find that problem early and intervene to hopefully prevent that problem from worsening. And so that's one of the reasons that we do screening. We want to catch anything that's happening that's going to be negative to find it early, intervene early, and usually an early intervention, appropriate intervention, and continuing monitoring puts the patient at a lower risk of that problem escalating and causing them more severe issues. We also like to be able to tell patients what's reality and what's myth. There are so many myths out there, and sometimes I'm truly amazed at what patients tell me that they have either been told or what their perception is of something that has been told. And a good example of that is related to fertility. I have so many patients who come in and tell me that they were told they'd never be able to have children because they had cancer and they had cancer treatment, so now that they're infertile. Well, we know which chemotherapies and which radiations put a person at risk for infertility. We also know it's also dose related. So I have patients who've told me that they're infertile and they're never going to be able to have children, and they actually had no treatment that puts them at any greater risk of having infertility than what occurs in the general population. And so we want to give them that accurate information. We don't want them to go through life thinking a certain thing when that isn't accurate. And I will be honest, I've had a lot of patients who end up having unplanned pregnancies because they thought that they were infertile. And so we give them that information, we dispel that myth. Now, sadly, there are many patients that do have treatment that can cause infertility, and we give them that information as well, and we tell them what interventions can potentially help with that. For example, there's a category of chemotherapy agents called alkylating agents, and that includes things like cyclophosphamide, ifosfamide, etc. We also know that the risk of infertility is based on the dose that they received. We also know that when patients have those chemotherapy agents, the female patients that is, they are at greater risk of going into premature menopause, meaning they'll go into menopause younger than the age of 38. So for women who had high dose alkylating agent chemotherapy, if they are in their 20s and they haven't gone through menopause, we always suggest that they have an evaluation by a fertility specialist to see what their risk is of developing premature menopause. And so early intervention, I've had female patients in their 20s who got checked out. They still had fertility, but it was significantly lower than the fertility you would anticipate for someone of their age. And part of that, how they're looking at that is there's a thing that can be done, such as high resolution ultrasounds of the ovaries that can tell you how many eggs are in the ovaries or the follicles that are in the ovaries. So if you have someone who doesn't have the amount of eggs that you would anticipate for their age, then they can have discussions about, do they want to do an egg harvest if they want a point in their life that they want to have children, but they might want to have children down the road. So it's also about just giving options, knowing information, and then giving options about what you can do with that information you've been told.
Karla, so what drew you to participate in this kind of work and research?
I think a lot of different things did. I started out working in pediatric oncology in the 1970s when the cure rate was relatively low. And throughout my career, I was a bedside nurse for 10 years before I became a nurse practitioner. And I've seen so much happen in the field of pediatric oncology. Some of the older survivors can appreciate some of these things. I started out in the days when we did not have IV pumps. We did not have central lines. We did not have good medicines to give conscious sedation for doing painful procedures. And as time went on and technology changed and we had so many improvements, one of the biggest things that I thought was a fabulous improvement was when we had the access to good anti-nausea medicines, and that revolutionized people's ability to tolerate their therapy. Things like colony stimulating factors that help the white count to recover quicker. It allowed us to give more therapy. Having good screening tools such as CT scans and MRI scans When I started out in pediatric oncology, there was one CT scan in the state I lived in. And now every hospital in the country has more than one CT scan. MRI scans didn't come out until the mid 80s. Central lines came out pretty much in the late 70s and early 80s. And that really revolutionized the comfort level for patients getting therapy. So I've been on that whole continuum. For a long time, I subspecialized in working with kids with neural tumors, so brain tumors, neuroblastoma, things like that. I also specialized in pain management and end-of-life care. And as we have more and more survivors, and I'm going through my own trajectory of being a pediatric oncology nurse, it's like, what's that next step? And so in 2006, when I was asked to join this newly developed program at City of Hope that was going to be a clinical research program looking at issues for survivors, I thought it was just kind of a good way to continue in my own growth as a professional, working with patients who had been treated for cancer. We initially had our program patients, we followed the classic age that childhood cancer is for anyone who was diagnosed prior to the age of 22. Then in the last probably 10 to 15 years, there became a big focus on what was called the AYA movement, and that's adolescent young adult. And that is for people who were diagnosed prior to the age of 40. And so our program decided to include patients who had pediatric types of tumors, such as leukemia, lymphoma, certain types of germ cell tumors, brain tumors, et cetera. Oh, and the other big one in that age group is soft tissue sarcomas and bone tumors. So we started seeing those patients and screening them. So our program now screens patients for late effects of treatment if they were diagnosed prior to the age of 40. So we're probably the only place in the country that has that AYA component as part of a childhood cancer survivorship program. And so it's kind of, I have to be honest, as a professional working with pediatric oncology patients, and I started in the 70s if you lumped all pediatric oncology patients into one category, there was about a 20 to 25% survivorship. Now it's an 80% survivorship for that same population of patients. Or the most common type of leukemia that occurs in children, the cure rate is over 90%. So I've seen these huge increases in people being cured. And so now, as I'm coming towards the end of my professional career, being able to work with survivors, being able to see all of the wonderful things that have happened for these people. And I still call them kids, even though many of them are now young adults and even older. Seeing that what they made of their life, what a cure did for them, and being able to give people information that helps them become better advocates for their own general health long term. And so I think I look at survivorship as being part of the entire package of pediatric and AYA cancer. It's part of the continuum. And I'm been so fortunate and so blessed to be able to see all of the things and all the improvements and all of the good that has come out of the treatments, and how many people have not only survived, they've thrived. They've become adult professionals. They have families. Now we have childhood cancer survivors. Not only do they have grandchildren, some of them have great-grandchildren, because we have people who are in their late 60s and early mid-70s who are actually childhood cancer survivors. And it's been such a rewarding part of my career to see all of the positive things that have happened in these people who have survived. And what many survivors have done, there's an amazing amount of survivors that have gone into healthcare-related fields. There are an amazing number of survivors that have become advocates for fundraising, for research. We have many patients who tell us that they come to our clinical research program not just to learn about things related to themselves, but they feel it's a way of giving back, and that can help further the improvements that come in the treatment of childhood and AYA cancers.
Karla, I wanted to have you perhaps maybe speak to late effects or long-term side effects for survivors that you've seen in the survivorship clinic.
Yes. And Right before I start speaking of that, I think I want to add one other thing to what you were asking about the work and research. And I mentioned how many cancer survivors become some type of healthcare professional or researcher. It's not only the survivors, it's the siblings. And sometimes even the parents have gone back and done a second career in a healthcare related field. So I think that's another important part of survivorship care. What's happening to the family members of the patient? So now I'll switch in and answer the current question. We've learned a lot about late effects over the last 35, 40 years, and particularly in the last 20 some years. We know for many of the chemotherapy agents, if you receive this chemotherapy, it puts you at risk for this particular side effect. We've also learned that some of the side effects are not just that you had the chemotherapy agent, but the side effect might be based on what was the dose you received. Might be the dose at the single administration, or it might be the cumulative dose of that chemotherapy over long term. So when we think about side effects, we can really kind of categorize them into multiple areas. So we look at what are treatments that could impact cognitive function. We know that people who receive something called intrathecal methotrexate, and for all those patients with leukemia and non-Hodgkin's lymphoma, you're probably very familiar with this. You may not know it was called intrathecal, but what it means is that you received chemotherapy with a chemotherapy agent called methotrexate, and it was delivered directly into your spinal fluid by doing a spinal tap. So we know that people who had intrathecal methotrexate may have some executive functioning issues. Might be related to speed of processing. It might be related to math comprehension, etc. And again, I think one of the things that's so important to remember about late effects, it's risk. Just because you have a risk for something doesn't mean you will develop the problem. And as I mentioned, there are other things that might affect cognitive function. Chemotherapy called high-dose methotrexate or high-dose cytarabine can affect cognitive function. The worst treatment that potentially can affect cognitive function is cranial radiation. And again, the risk of the cranial radiation affecting cognitive function is based on the age that the child received it, as well as the dose they received, and also was their entire brain radiated or just the area where the tumor was. So we know that there are a lot of factors that contribute to the actual risk a patient may have from that type of radiation. We know that anthracycline chemotherapy, which I mentioned earlier, puts you at risk for heart-related problems. We also know that that risk is based on dose, the cumulative dose. We used to think that it was also based on the age the child received the first dose. We now know that the age doesn't matter. It's only the cumulative dose that matters. Somebody who had a very low cumulative dose is at lower risk of developing a heart problem. Patients who had high dose are at higher risk. So our screening for heart-related issues is based on the dose. If you were low dose, you're screened every 5 years. If you're high dose, you're screened every 2 years. And if we find an abnormality, and the screening is primarily done by echocardiograms, if we find an abnormality, depending upon the abnormality, we would refer you to a cardiologist, and the screening might change based on what the cardiologist feels is appropriate screening if you do have an issue. We know chest radiation can affect your heart as well. And so depending upon the dose of chest radiation depends again on the frequency that we would screen your heart. We know, as I mentioned earlier too, that alkylating agents may affect your potential fertility. Again, the cumulative dose is important. High cumulative dose puts you at greater risk. Low cumulative dose puts you at lower risk. This is a late effect, though, that is also related to whether you're a male or a female. Females who receive alkylator chemotherapy, if they are prior to puberty, they can actually tolerate a much higher dose before it impacts their potential fertility. Males, it doesn't seem to matter how old they are when they receive the alkylating chemotherapy. Their risk tends to be the same based just on the dose. So this is a situation, again, female versus male does make a difference on a risk for a particular problem occurring. There are, if you have radiation to an extremity or to your spinal area, that can affect your growth, it can affect your overall height, things like that. chemotherapy doesn't impact your overall growth, radiation therapy can affect your overall growth depending what area of the body was radiated. Endocrine late effects are another problem. And it might be if you had radiation that affected your thyroid gland, or you had radiation to the brain that affects the pituitary gland, you might have thyroid issues. You might have growth hormone issues if you had radiation that hit your pituitary gland. So we also know area radiated dose that you're given, again, impacts your risk for particular late effects. Then other issues are pulmonary. There are a couple of chemotherapy agents that can affect your lung function. Radiation to the chest can affect your lung function. So we typically, as a baseline, will do pulmonary function test. And depending upon what we find on that test, will impact what we recommend that is done. So again, getting the knowledge of where you're at can be very helpful to tell you what direction you need to go for continued monitoring and screening. Certain chemotherapies can affect your bone health. We know that steroids can cause something called avascular necrosis, where you have deterioration to the bone within a joint. And the classic ones that really tend to get affected are your femur, so your large bone in your upper leg. The top of that bone becomes kind of flat and raggedy, and so it doesn't move well within the hip joint. Same thing can happen in the shoulder joint. It can happen in the knees. Those are the most common bones affected. Then the other thing that can happen is that your bone density decreases, and you can develop something called osteopenia, which is premature thinning of the bones, or you can develop osteoporosis, which is a more severe form. And if you have thinner bones than what you should have, that puts you at greater risk for having a fracture. And people tend to know about osteopenia and osteoporosis when you think about the elderly, particularly postmenopausal women. That's when you tend to be at greatest risk for that developing. It can occur at a younger age if you've had certain chemotherapy agents, particularly again, steroids, and then actually methotrexate are the big ones. So we've learned a lot. What's your risk? What agents, what treatment affects what different organs? So if you had something that can impact your liver, we look at what's your liver function. Is your liver function healthy? If you had therapy that can affect your kidneys, is your kidney function normal? Is it healthy? What are things you can do to continue to have good liver health and good kidney health as you age? And so when we look at chemotherapy agents and radiation, we really look at what organs do they affect and what is the risk factor for the individual patient. And again, based on their treatment exposures, then we can tell them, this is what you need to have screened. This is how often you need to have this screening, and go forward from there as far as what we're going to recommend that they do if a problem is found. Oh, and then the other thing that kind of falls into that late effect component that I didn't mention at all, and it's extremely important, are issues related to your psychiatric function. Do you have issues with depression? Do you have issues with anxiety? Do you have issues with fatigue? And chronic fatigue can be a huge problem for many people. Do you have issues with residual pain? Did you have a bone tumor and you have a limb salvage procedure and your joint isn't functioning quite like it should be as far as compared to your normal? Or did you have an amputation and you have problems with your prosthesis and how your amputated extremity fits into the prosthesis? Many people tell me that they start getting anxious a few days before they have to come to the clinic, and they remain anxious until they get all their test results back. So I personally feel it's imperative that we communicate with patients as rapidly as possible as soon as we get the test results back. And I have patients who tell me when I call them with their breast cancer screening result or their echocardiogram or whatever, they say, oh, now I have a huge sigh of relief and I don't have to worry until the next time. So I think having that knowledge can really help people. I have a lot of patients who will come into the clinic and their blood pressure is high, higher than it should be for their age and their general health condition. And they'll say, when I go to my primary care doctor, my blood pressure is normal. It's only when I come here that it's elevated. And it's because there's a certain degree of anxiety about, am I going to get bad news? Or sometimes it's because it brings back the memories of going through the treatment. I have a young woman that I see who actually had leukemia as an infant. And she was actually in the days before we had central lines. So all of her therapy was related through IV sticks in her extremities. She tells me, and actually I shouldn't say, she's actually not just a young woman anymore. She's now in her 40s. She tells me she remembers nothing about her cancer treatment because it was done by the time she was 18 months old. But she has horrible needle phobia. And I'm sure that needle phobia is related to all of the needle sticks that she had while under treatment. And even though she doesn't remember the actual treatment, there's something in her brain that makes her afraid of needles. And I'm 100% sure that it's related to that treatment. So sometimes people will not realize they have a problem or they can't express it. So it's part of our clinic. The first time a patient comes, we offer them an assessment by a psychologist. And then depending upon what they feel, what the psychologist feels, et cetera, we might recommend that they get counseling or therapy or follow them up in another year or so to see if things are still going okay. We do have patients with cognitive issues, as I mentioned, and we offer them neuropsych testing so they can get an assessment of how they learn. What are their strengths and weaknesses in their learning? What are strategies that they can use to help use their strengths to compensate for some of their weaknesses? So we don't want to just screen people and say, hey, you have this, you have that. We want to screen people and then give them the information needed to address the problem that has been found.
Okay. I am curious, how prevalent are secondary cancers and reoccurrences?
That's a really good question. And I can't give you total data, but I will give you general information.
Okay.
For most people, the incidence of relapse for people with leukemia and lymphoma is within the first couple of years of coming off therapy. And it's actually a very low incidence. And it depends on the type of tumor. Someone with Hodgkin's disease, the relapse might be a year or two later. Usually with leukemia, less than 5 to 10% of people will relapse when they are off therapy, and it's usually the first year out. The longer you go, the less likely you are to have relapse. And what are your risk of secondary cancers? Part of it's dependent upon your treatment. If you had radiation, there's a pretty high risk of developing skin cancer. If you had radiation that hit your thyroid gland, you have a higher risk of developing thyroid cancer than someone who did not have radiation. Just because you had this treatment, does it mean you're going to develop those issues? No. But realistically, you do have a greater incidence than the general population. Women who receive chest radiation have a much greater incidence of developing breast cancer within probably 20 years, 30 years of their treatment. So developing breast cancer at a much younger age than what you think of as the average age of someone developing breast cancer. From kind of a general statement, about 1 in 8 women will develop breast cancer within their lifespan. If a woman has had radiation to their chest, 1 in 3 women will develop breast cancer within their lifespan. And that's why we start breast cancer screening at age 25 or 8 years after the radiation was done in those women. Women who did not have radiation to their chest, to our current knowledge, are not at greater risk of developing breast cancer than the general population. So we know certain things are put you at risk. And when something is going to put you at risk, we do screening. If you did not receive treatment that puts you at risk for developing breast cancer, there's no need to start screening earlier than the general population, which is recommended at age 40. Now, I'm taking into account, we're not discussing whether there's a genetic predisposition. Certainly, if a patient has a genetic predisposition, things might recommend it differently. There are certain types of syndromes that put people at greater risk for cancers. So if somebody has something called neurofibromatosis, they're at greater risk for developing a cancer than someone who doesn't have neurofibromatosis. Retinoblastoma, which is a cancer of the retina of the eye. If your parent had retinoblastoma, you have a greater chance of developing that. Now, that's a tumor that occurs in infants and preschoolers primarily. So if you have a child who you are a survivor of retinoblastoma and you have a child, that child's going to get screened with good eye exams to make sure that they don't develop retinoblastoma. I shouldn't say don't develop it, but that if they do develop it, intervention occurs early. So it really there's a lot of factors into the risk of secondary cancers. And most reoccurrences occur early, but nothing's written in stone. I've had patients who have relapsed 20 years out. It's not unheard of, but it's rare. I think it's important to know for people to know potential risk factors. We know that people with leukemia, again, the most common time of relapse is while on initial treatment or within a year or so of finishing treatment. The further out, the less likely. In fact, the Children's Oncology Group long-term follow-up guidelines say that the incidence of recurrence is so low that we don't need to do routine CBCs once they come to survivorship clinic because their incidence of relapse is very, very low. Not zero because nothing's zero.
Well, Karla, I wanted to ask if you could speak a little bit to the maybe recommendations for preventative care. I was certainly hearing that you were starting to talk about just like the normal screenings and other things that would be helpful for those who are survivors. So I just wanted to perhaps have you speak to that.
Okay. So if a person has a risk factor because of their treatment, then they're going to start screening early. And I already mentioned breast cancer, women start screening either at age 25 or 8 years after their radiation treatment. Colon cancer screening for people who had radiation to their GI tract starts at age 30 or 5 years after radiation. If you did not have those treatments, you follow the normal screening practices. Normal screening for the general population of women is for breast cancer is starting at age 40. For colon cancer, it actually used to be age 50 for the general population. That has decreased to age 45. And so I believe prostate cancer screening is age 50 for men. So whatever the general health screening guidelines are, is what we recommend to people who do not have a treatment that puts them at a particular risk for those early screenings. Now, skin cancer screening is based on, again, radiation. So people who had radiation need to be checking their skin. And I frequently do recommend people who have total body radiation, they might want to have a yearly appointment with a dermatologist to do a full skin cancer screening. But people who had a history of sunburns as children, they might also need to start screening early for skin cancer with a dermatologist. So it's very individualized based on your history. Now, if you have a family member who had colon cancer and there's been a genetic evaluation, even if you didn't have radiation to your GI tract, you might need to start colon cancer screening, but that's based on the recommendations from a genetic counselor. And it's only if you have that gene, if your family member has the gene and then you get tested and you have the gene, that's going to impact screening. But in general, many cancer survivors just get the screening done for the average population, meaning people who have not had cancer treatment. But again, it's very specific based on what your cancer treatment was as to what screenings you should start and when.
And I imagine this question is going to have maybe the same flavoring here, but I was just curious if you could speak to maybe some multicultural issues. I'm hearing that really the survivorship clinic is going to be looking at individualized treatment and care and what that means for the patient in the clinic. But just wanted to have you maybe speak to that as well.
Yeah, if we can look at multicultural issues in a lot of ways, and if you're in the healthcare world, one of the big things that's really been being looked at in the last several years is access to care. Are people who are of different ethnicities not having the same access to care? And that's a whole nother area. And it's not just related to survivorship. It's related to healthcare for the general population. But when I look at multicultural issues in survivorship, I look at a couple of different things. We always ask people what their ethnicity is. And the reason it's important to know ethnicity is certain ethnic populations may be at greater risk for certain types of issues. So, for example, people of Indian heritage, and when I mean India, the continent of India, they tend to have a higher incidence of having issues with cholesterol, particularly with something called the triglycerides. People who are of Hispanic heritage might be at greater risk for developing gallbladder disease at a younger age. People who are of African American heritage might be at greater risk for hypertension. Certain ethnic populations are at greater risk potentially for things like diabetes. So knowing ethnicity as well as, and when I look at the cultural area, I look at the family culture, families. You have a lot of people in your family who've had heart disease. You have a lot of people in your family who have diabetes, particularly type 2 diabetes. Do you have a lot of people in your family that have high blood pressure? Do you have people who have kidney disease? So it's really important to know that family history as well, because you might be at greater risk for a problem related to your family history than you are related to your cancer treatment history. So it's really helpful to kind of, for a healthcare provider, to also read the literature about what cultural issues might impact screening for patients in survivorship. So just because somebody is whatever ethnic or cultural race, it might mean they need this screening a little bit differently than someone who's of a different cultural race. But in survivorship, we really screen based on the treatment exposures, but knowing what multicultural types of risk factors you might have can be taken into account when you're thinking of screening as well, as far as what you might recommend to the patient, what you recommend to the patient regarding diet and exercise. All of those things are so important. Life would be so much easier if none of us had risk factors for anything. But in reality, all of us have potential risk factors. And when you look at your basic risk factor based on your family history, and now you add on that you had a treatment that also increases your risk factor for a particular disease. So, for example, if you have a strong family history of type 2 diabetes, and then you had total body radiation, that increases your risk of developing type 2 diabetes because of the radiation. But if you have a family history, sometimes it's kind of like 1 + 1 = 3. So if you've got a risk factor based on your culture or your family history, and now you had treatment, maybe your risk factor is going to be escalated. And so it becomes even more important that you try to have good, healthy lifestyle practices like exercise, healthy diet, making sure you have omega-3s and fiber and lots of fruits and vegetables and things like that in your diet to decrease the chance of those diseases coming out. I'm not quite sure if I really answered your question there.
That sounds like a good answer to me, Karla. Yeah, I mean, there's a lot of different risk factors associated with different ethnic groups, which I think you kind of answered.
Yeah. And I'm sure as a nutritionist, Dustin, you see a lot of that.
Yeah, and I also see a bit of resistance to share that information as well for just, I guess, personal reasons. People just want to be treated the same.
I agree with that.
Yeah, I guess there's like less awareness around some of the research that's out there for different ethnic groups have different health risks that, we have to screen for.
Yes. I actually sometimes very occasionally I'll have a patient that say, "Why do you care what race I am?" And then, when I've had people ask me that, I try to make sure now that when I'm seeing a new patient that I upfront say, "I'd really like to know what your ethnicity is, because there are certain things that put you at greater risk based on your ethnicity or your family history." And that's why it's so important to have that as part of your medical record, because it tells us you might be at greater risk because of this ethnic or family history. And it's not just related to the cancer treatment.
So, yeah, as a cancer survivor, what type of long-term screening do I need? And how does my past cancer treatment history impact normal health screenings? This is just like a general question for our listeners. I feel like you did touch on some of this, but maybe you could go into it in more depth, age or any other factors that might be related.
Okay. So, as I said, we now have the long-term follow-up guidelines through the Children's Oncology Group, and that really directs us into what screening is needed. So before I ever see a patient in our clinic, prior to them coming to the clinic, we develop a comprehensive treatment summary that says, you had this disease, you had this treatment. Based on the treatment you had, we know that we need to screen you. If you had anthracyclines, we'll screen your heart. If you had steroids and methotrexate, we will screen your bone density. If you had radiation that hit your thyroid gland, we will screen your thyroid function testing. If you had total body radiation or radiation that to your abdomen. We're going to screen you for diabetes and for cholesterol issues. And we're going to start those screenings now. If you had chest radiation and you're a female, we will start your breast cancer screening when you're 25, or we will start it 8 years. If you happen to be 20 when you had chest radiation, we'll wait till you're age 28. So we screen for 8 years after the radiation or age 25, whatever occurs last. And now that we see patients who are diagnosed up to the age of 39, we look at just when we have patients who are diagnosed at 22 onward, we start that breast cancer screening 8 years after. Colon cancer screening is the same way. We only screen for colon cancer if you had radiation that affects your GI tract. That starts at age 30 or 5 years after the radiation. So for both of those diseases, for the general population or for patients who had cancer treatment but didn't have a treatment that puts them at greater risk, they start colon cancer screening at age 45 and breast cancer screening at age 40. So they get the normal general population-based screening if their cancer treatment did not put them at risk for developing it at a younger age. Bone density, in our clinic, we screen patients who are at risk for premature thinning of the bones at age 18. The general population is usually around 50 for bone density screening. So again, you're going to start that at a much earlier age if you have treatment that puts you at risk. If you didn't have treatment that puts you at risk, again, you would start that screening at the same time as the general population. I'm trying to think what other screenings that are done for the general population. Those are the big ones: breast cancer, colon cancer, and bone density. Also prostate cancer screening in males. That one's a little bit different. In general, the screening just starts at the normal age, and those age ranges are developed by the United States Preventive Task Force and their recommendation of screening for the general population. So everything is, again, screening based on your treatment exposures starts at a specific time based on the recommendations through the Children's Oncology Group. And we're pretty dedicated to following the Children's Oncology Group screening. Now, obviously, if I saw a patient and as part of her physical exam, I did a breast exam on her, and I find something on the exam, we're not going to wait till she turns 25 to do that breast cancer screening.
Well, Colin, do you have anything else that you'd want to ask at this time?
I think I just wanted to thank Karla for her expertise and willing to then share her work and research at the Survivorship Clinic at the City of Hope. So thank you so much for being able to share that wealth of knowledge that you have.
Thank you very much for asking me.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey.